Today's presenter is Dr. Will Wang, and I'm Steve Lippman, the backup guy. We're going to talk today about the release of aducanumab, which came out with a great deal of anticipation and hope. First drug in a long time that was supposed to treat Alzheimer's. None of the previous ones did anyway. The journal for today is from The Lancet. It's an Insight article entitled A Resurrection of Aducanumab for Alzheimer's Disease. Just 2 pages, it's readable. The FDA approved aducanumab for prescribing in June of this year, but despite the excitement, came out with much controversy because of irregular protocols and scrutiny about the research. And this is particularly interesting because at the end of last year, the FDA's own advisory committee voted 10 votes not for approval and 1 vote for approval. So it further puts distrust about the FDA's professionalism and review process. It also puts the drug under greater scrutiny and hesitancy. And it's particularly sad because here we are in coronavirus pandemic trying to boost FDA confidence in their vaccination plans. And bingo, we're showing that the review process of FDA is sometimes somewhat under question, creating more distrust about the FDA's decisional process. So let's hear about aducanumab. Dr. Wang, why don't you take it away?
Thank you, Dr. Lippman, for that wonderful introduction. Now, I also want to thank Dr. Lippman for his guidance through this presentation. Today we're talking about a paper by Dr. Knopman, and so essentially what we're talking about is whether aducanumab is the future of Alzheimer's disease treatment. And I declare no conflict of interest in this presentation. And we have 6 goals and objectives in today's presentation. First, we want to define the Alzheimer's disease, mild cognitive impairment, as well as preclinical Alzheimer's disease. We want to understand the clinical tools of Alzheimer's disease assessment, as well as tools of dementia assessment in general. We want to talk about the variety of biomarkers, both biochemical as well as CSF, as well as imaging biomarkers for the study of Alzheimer's disease. We want to review the available Alzheimer's disease treatment that were available before the approval of aducanumab in June of 2021. We want to critically think about the phase 3 clinical trials of aducanumab, as well as appreciate Dr. Knopman's failure to demonstrate efficacy of aducanumab. We want to discuss the FDA accelerated approval process for aducanumab, the labeling issue of aducanumab, the cost of this medication, as well as access issues for this medication. And last but not least, since we're psychiatrists, I want to briefly talk about what the approval of aducanumab means for psychiatrists. So we dive right into the National Institute of Aging Alzheimer's Association definition of probable Alzheimer's disease. It requires the presence of dementia as well as the following. Number 1 is functional difficulties. Number 2, there has to be a decline. The patient can't be functioning at a low level as their baseline. There has to be a decline. Number 3, subjective and objective history of dementia and decline. The impairment must involve 2+ domains, and some of the examples of the domain include memory, language, visual spatial skills, executive function, etc. There has to be other core clinical features, and these are not listed, but they include insidious onset as well as things such as a clear-cut clinical history of decline. And last but not least, we must rule out other sorts of medical illness or psychiatric illness that can sort of present this way, such as other forms of dementia, delirium, major psych conditions, other medical conditions, as well as cognition-altering medications that could explain the change. Now we sort of want to talk about the mild cognitive impairment, and specifically we want to talk about the amnestic mild cognitive impairment because it is thought of as a prodrome to Alzheimer's disease. The definition of single domain AMCI is that there must be subjective and objective memory decline or complaint. The patient must have relatively normal functional abilities, and they must not meet criteria for dementia. However, in order to say an amnestic MCI is specifically due to Alzheimer's dementia, biomarker evidence is actually required. So you can't just diagnose MCI due to Alzheimer's disease clinically. You must have biomarker evidence, and we will talk about the biomarker evidence in some later slides. Amnestic MCI that affect multiple cognitive domains, such as memory and language, have unclear prognostic values according to a study. And non-amnestic MCI is less frequently associated with Alzheimer's disease. And an example is an MCI that affects only language, but not memory. So preclinical Alzheimer's disease is a patient who already has molecular pathology of Alzheimer's disease, but is clinically asymptomatic. Here I have sort of have an image of the National Institute of Aging framework of preclinical Alzheimer's disease. As you can see, as patients progress through the stages, you start from having amyloidosis to having neurodegeneration to start having subtle cognitive decline that does not yet meet criteria for mild cognitive impairment. And eventually, as patients progress through these stages, they may get Alzheimer's dementia. And that is because some symptomatic Alzheimer's disease will not actually occur in everybody with high brain amyloid. And that is saying some patients will actually not progress beyond stage 1 or 2, meaning they just have the amyloid pathology, but they don't have any symptoms. So now I sort of want to switch gears and talk about the clinical tools of Alzheimer's disease assessment. There are numerous tools, and I will sort of talk about the important ones that are relevant to our discussion today. Essentially, we use Montreal Cognitive Assessment and Mental Status Exam quite frequently in our day-to-day clinical practice, and you can see the score cutoffs for significant cognitive impairment. The repeatable battery assessment of neuropsychological status, RBANS, is a neuropsychological testing that can be used to assess dementia, and the average is about 100 points. I want to emphasize the clinical dementia rating scale because this is the rating scale that is used in the clinical trial for aducanumab. In fact, it is used at the primary study endpoint for aducanumab. There are two methods of calculating the results of the score. The study chose to use a summary of boxes. Interesting about this clinical tool assessment is that the greater the score, the greater the impairment. So lowering of the score actually means clinical improvement. Score greater than or equal to 0.5 indicates possible cognitive impairment. And then I want to sort of mention the ADAS-Cog13 as well as the ADCS-ADL-MCI scores as well, and they're used in the phase 3 clinical trial for aducanumab as well as secondary endpoints. So here's an example of the repeatable battery assessment of neuropsychological status scoring sheet. And as you can see, about 100 is average. And here is an example of the clinical dementia ratings scale that is used as the primary endpoint in the aducanumab clinical trial. And as you can sort of see, if you score a 0.5 in this scale, then you questionably have some impairment, but nothing significant, I guess, in a way. But if you score 1, you would have a moderate memory loss if you scored 1 in memory. So scoring 1 and above may be mild to moderate, yet it is a significant impairment. And again, this CDR scale is used in the clinical trial. And here is the summary of some of the domains that the ADAS-Cog scale use. And this is a secondary endpoint assessment tool in the study. And so is the ADCS-MCI ADL scale. So now I sort of want to talk about some of the biomarker assessments of Alzheimer's disease. These biomarker assessment tools are actually not currently used routinely. They're mostly used only in for research purposes. However, since aducanumab is a disease-modifying therapy, one thought I had was perhaps some of these biomarker assessment tools will have a bigger role in day-to-day clinical practice in the future, as you're actually targeting these things. So neurologists may have an interest in actually tracking these biomarkers. And we are all familiar with the beta amyloid protein. That is, it is an abnormally cleaved version of the amyloid precursor protein. They congregate to form amyloid plaques, and this is thought of as one of the 2 primary pathophysiology of Alzheimer's disease. Clinically speaking, in the CSF, a low CSF concentration of A beta 42 or low CSF concentration of A beta 42 to A beta 40 ratio are some of the signs of Alzheimer's pathology. Alternatively, you can use a PET scan using amyloid-specific tracers. And this is different from a PET scan using the normal glucose tracers because it is specific to Alzheimer's disease pathology. The tau protein is the other major pathophysiologic causes of Alzheimer's disease, at least the scientists think. It is a microtubule-associated protein, and they accumulate to form the neurofibrillary tangles. In the CSF, high CSF concentration of tau, as well as high CSF concentrations of phosphorylated tau are some signs of Alzheimer's pathology. Similar to beta amyloid, you can also do a PET scan using tau-specific tracers to see the tau pathology in the brain. And now we sort of come to the ApoE gene, and it is actually an apolipoprotein E. It is a cholesterol carrier, and it is involved in some of the processes in injury repair, as well as it supports lipid transport. So the ApoE E4 allele actually increases the risk of Alzheimer's disease when compared to the ApoE E3 allele, which does not. In one study, 2 copies of the ApoE E4 gene actually increases the risk of Alzheimer's disease by about 8 to 12 folds. So here I will present some of the imaging assessment tools of Alzheimer's disease. First, I want to just mention the PET, the amyloid or tau-specific PET imaging again. And these are pathophysiologic evidence of Alzheimer's disease. The normal MRI scan can actually also be used to study Alzheimer's disease, and the characteristic findings in AD is hippocampal or medial temporal lobe atrophy, as you can see here. And it serves as a topographical evidence only because it does not use a pathophysiologic tracer, but rather just looks at the morphology of the brain. The third assessment tool is PET scan using the normal glucose or FDG tracers or SPECT scan. They can reveal the hypometabolism in PET scan and hypoperfusion in SPECT at hippocampus, mesial parietal lobes, lateral parietal lobes, and posterior temporal cortex. Naturally, the pathophysiologic evidence is more specific to Alzheimer's pathology, yet the topographical evidence with MRI or PET or SPECT scan correlate more with the clinical symptoms of cognitive impairment. So here is a table that sort of summarizes all the pathophysiologic markers of Alzheimer's disease and the topographical markers of Alzheimer's disease. As you can see, the markers that are used for pathophysiologic evidence are not markers of topographical evidence in general. So there are actually 5 FDA-approved Alzheimer's disease treatments prior to June of 2021. And I think one of the FDA-approved treatment is a combination of the two. So essentially, there are 2 categories of treatment. And the first category of drugs target are cholinesterase inhibitors, and they include donepezil, galantamine, and rivastigmine. I think we use donepezil quite often in our day-to-day practice. And these drugs are actually indicated for both mild to moderate as well as moderate to severe dementia. So essentially for everybody with dementia due to Alzheimer's disease. However, the disappointing fact is that studies have only shown pretty modest improvements in cognitive scales with cholinesterase inhibitor. And I have a chart here that sort of is a study over 24 weeks of donepezil using a ADAS-Cog rating scale. As you can see, the improvement at the end of 24 weeks is only about 2 points on a 70-point scale. So studies have found that they essentially prevent a 2-month per year decline. However, the evidence for long-term outcomes is unconvincing, and these long-term outcomes include nursing home placements as well as day-to-day functioning in ADLs. The second mechanism that we target is an NMDA receptor. It is an antagonist to NMDA receptor, and the name of the drug is memantine. It is only indicated for moderate to severe dementia, and it has no evidence in mild to moderate dementia. But similar to cholinesterase inhibitors, only modest MMSE improvement, and it really has no effect on the rate of nursing home placement over the study period of 4 years in one study. And here you can see essentially a study of placebo, donepezil alone, donepezil plus memantine, and memantine alone. And you can sort of see the circle is active donepezil and active memantine. And it does lead to the least amount of MMSE decline over 52 weeks. However, the decline is only about, the slowing of decline is only about 3 points on a 30-point scale. All right. So
there were other drugs, by the way, before these. One was a triple ergot alkaloid combination, but also it didn't work very well either. Maybe they don't all, maybe all of them don't work. A lot of subjectivity there.
Right. Thanks, Dr. Lumen, for that. So now I sort of want to switch gear to sort of start talking about aducanumab and some of the background of the development and submission of approval of this drug. the mechanism of action is that it's a monoclonal antibody that is directed against the beta amyloid. Around the same period, there are actually other manufacturers that are actively researching amyloid targeting antibodies. And these include gantenerumab and solanezumab. Some of these trials have been deemed futile. However, I think there is actually a combination study of gantenerumab and solanezumab in the familial version of Alzheimer's disease. So some of the drugs are actually still actively being trialed. So aducanumab, the main topic of today's discussion, it was in a phase 1b clinical study in 2016, and it showed promise. Around the same year, a phase 3 trial of aducanumab began. Actually, a pair of phase 3 trials. The interesting thing about this pair of trials is that initially the ApoE4 carriers were only allowed to be titrated up to 6 mg per kg, while the carriers were able to receive the full dose of 10 mg per kg. And this was due to the concern of the ARIA-E side effect, which stands for amyloid-related imaging abnormalities - edema. However, interestingly,
means edema of the brain.
Yes. In March of 2017, the study protocol was actually revised, and the ApoE4 carriers were all allowed to have 10 mg per kg, just like the non-carriers do. And this is due to some new study findings that the ARIA-E side effects are actually generally benign. In March of 2019, the pair of trials were halted because of futility. One trial was trending positive, while the other was trending negative. In October of 2019, Biogen, the manufacturer of aducanumab, actually did a post hoc analysis of both trials. And this post hoc analysis was able to suggest that the high dose groups from both trials actually had clinical efficacy, as opposed to one trial being positive while the other being negative. So this sort of served as their ground for submission for FDA approval. And they presented their intention to treat, meaning the initial results of one trial being positive while the other one being negative, as well as the post hoc analysis. They presented both results in a presentation to the public. In July of 2020, aducanumab was submitted for FDA accelerated approval. And 1 year later, in June of 2021, the aducanumab is approved for mild cognitive impairment as well as mild dementia due to Alzheimer's disease. So now we dive right into the phase 3 clinical trial itself. So these are a pair of identical trials that study patients over 18-month period. They're randomized, double-blinded, placebo-controlled. The population of the study have early Alzheimer's disease, namely MCI or mild dementia due to Alzheimer's disease. They're characterized via a variety of clinical assessment tools, and importantly, they also all have confirmed amyloid pathology. So I don't think they presented how they confirmed the amyloid pathology, but they say that they confirmed amyloid pathology for all patients. The doses, so there are 3 groups of study. There's a placebo group, there's a low dose group, and there's a high dose group. And the design is the same for both trials. The primary endpoint, as we talked about, is a clinical dementia rating scale summary of boxes. And there are a number of secondary endpoints as well as the biomarker studies. So here I will sort of talk about the relatively complicated dosing regimen of the phase 3 clinical study. So Before and after the revising of protocol, the low dose group was actually unchanged, meaning that the carriers always received up to 3 mg per kg, and the non-carriers always receive 6 mg per kg, if they can tolerate it. However, prior to the changing of protocol, the carriers received only 6 mg per kg, while the non-carriers received 10 mg per kg. While after the change of the protocol, carriers and non-carriers in the high dose group received 10 mg per kg. And the takeaway is essentially the high dose groups in both trials, their dosing regimen is changed after protocol version 4. So here is sort of a scheme of the pre and post protocol version 4 dosing regimen for the high dose group. As you can see, pre-protocol change, the carriers have opportunity to receive up to 6 mg per kg, and the non-carriers 10 mg per kg. And the post-protocol revision, everybody have an opportunity to receive 10 mg per kg. And that is due to the new studies that point to the fact that the brain edema side effects are actually benign, as we talked about. So the takeaway from this slide is that post-protocol change, patients in the high dose group are exposed to more aducanumab. So this will actually be used as sort of an argument by Biogen to say that their drug is effective. So here is the intention to treat analysis of the primary and secondary endpoints. And we can sort of see the two identical trials are presented side by side. One is called Emerge and the other is called Engage. The primary endpoint is displayed right here. It's a clinical dementia rating scale, summary of boxes. The higher the score, the bigger the decline. And as you can see in the high dose group of Emerge, there is a statistically significant improvement of the clinical dementia rating scale of minus 0.39. While in the Engage trial in the high dose group, there is actually a worsening of dementia because there is an increase in this scale, although it's not statistically significant. So essentially, the takeaway from this intention to treat analysis is that when pre and post protocol change patients are analyzed together, one study is trending positive and the other study is trending negative. And you would sort of naturally ask, why are two identically designed clinical trials having a very divergent result? And this is a slide that was actually shown in Biogen's presentation to the public. And it is sort of a very fancy slide that shows everybody's dosing regimen. But essentially in the small letters at the top, Biogen pointed out that 29% of patients in Emerge and only 22% of patients in Engage received the full possible 14 doses of 10 mg per kg aducanumab. So essentially, what they are claiming here is that despite the fact that both trials are designed identically, it is due to the fact that more patients in the Emerge trial than in the Engage trial received the full 10 mg per kg dose that there is a divergent outcome. So they're saying more drugs is causing the positive outcome in Emerge, while less drugs in Engage is causing the negative outcome. So they're essentially implicating that the drug is effective. So they went on as a result to do a post hoc analysis of both the eMERGE trial as well as the ENGAGE trial. Essentially what they did is that they took a subset of patients who consented to the PV4 protocol before week 16, who got 14 doses of placebo, low or high dose of aducanumab. And the difference in the post-PV4 analysis is that all patients in the high dose group received 10 mg per kg, as opposed to either 6 or 10 mg per kg in the intention to treat analysis, which is the original analysis that showed divergent outcome. So to their pleasant surprise, both trials actually showed positive results. As you can see, both eMERGE and ENGAGE in the post hoc analysis showed a clinical improvement, which means a decrease in decline of the CDR-SB scale. And the decrease is significant in the eMERGE trial, about a -0.53, while the ENGAGE trial showed a similar treatment effect of a -0.48. However, it does cross 0. However, as you can see, the majority of this confidence interval lies below 0. So there's a good chance that just based on the stats here that ENGAGE is showing a positive effect of aducanumab in its high dose group. Essentially, what Biogen is saying in this analysis is that, voila, told you, if we analyze people exposed to a higher dose, we will get positive results. And they did get positive results for both trials. And now we sort of, oh, sorry, I skipped a slide. Okay, now we sort of come to the paper that we sent out for today's journal club. And Dr. Knopman from Mayo Clinic, he sort of provided an alternative explanation of why there is a divergent outcome in the intention to treat analysis, as well as why ENGAGE is showing positive results in the post hoc analysis. So if you shift your attention to only the left side of the table, the intention to treat analysis, you can sort of see that the eMERGE trial and ENGAGE trials placebo decline are actually quite different. And you know, the eMERGE trial has a placebo decline of 1.74, while the ENGAGE has a placebo decline of only 1.55. And it is quite curious why the placebo had showed such different decline when you have essentially an identical trial design. And essentially what Dr. Knopman is claiming here is that the reason why eMERGE is showing effect while ENGAGE is not is because the placebo group actually declined more in the eMERGE trial when compared to the ENGAGE trial. So he went on to compare the ENGAGE trials before and post the post hoc analysis. And as you can see, there's also a pretty significant placebo difference here, 1.55 versus 1.79 in the post hoc analysis. And he went on to say that this is the reason why the ENGAGE trial turned positive in the post hoc analysis. And something very interesting that he pointed out in his paper as well is the fact that the low dose group actually showed a doubling of effect as well. Why is this interesting? It is because the low dose group, if you remember from the trial design, there was no change of the low dose group before and post the protocol version 4 change. Namely, everybody received the same dose of drug even after revising the protocol. As you can see here, the treatment effect of post PV4 low dose in ENGAGE is almost double the treatment effect in the intention to treat analysis. However, again, if you look at the placebo decline, the post-PV4 group has a much more remarkable placebo decline. So he's arguing that the bigger placebo decline in the post-PV4 group is explaining the doubling of the treatment effect in the low dose group in the post hoc analysis. And this is, clearly abnormal and curious. So Dr. Knopman went on to cite a study that sort of investigates the progression of MCI in placebo groups in various studies of Alzheimer's disease treatment. And this is a study that was published in 2017 in the Journal of Neurology. And it sort of takes a look at the placebo group performance of our various clinical trials. And you can sort of see that all the studies, placebo groups sort of start out at similar levels around between 0 to 2 on the clinical dementia rating scale, but they end up drastically different at the end of the study period at 25 months. The worst performing study shows a CDR-SB scale of around 6, and the best performing study shows a CDR-SB result of 4. So Dr. Knopman is arguing essentially that it is very difficult to predict the clinical performance of placebo groups, and it is just quite difficult to control. And this sort of explains the divergent placebo group performance in the original intention to treat analysis. So now we sort of switch gears to talk about the biomarker analysis in the clinical trial. And to their pleasant surprise, you can sort of see that both eMERGE and ENGAGE trials showed a dose-dependent decrease of amyloid on PET imaging. The gray line is the placebo, the blue lines are the low dose group, and the purple lines are high dose. Essentially, the vertical axis is concentration of amyloid on PET imaging, and you can sort of see that there's a dose-dependent response. So Dr. Knopman actually says the result here is actually quite convincing that aducanumab does lower beta amyloid in the brain PET, and it probably does. However, he does raise a question, the convincing A beta lowering effect, but mixed clinical results raise this question about whether there is really a causal link between beta amyloid lowering and actual clinical cognitive benefit. So, and they also did some other biomarker studies, including the tau CSF, and both ENGAGE and eMERGE investigated the phosphorylated tau as well as total tau. And I think the only convincing sub-study here is the phosphorylated tau in the eMERGE trial, where there is a dose-dependent decrease in phosphorylated tau that are statistically significant as marked by those star signs. However, the rest of the studies are sort of mixed. So no conclusion can be drawn about tau CSF lowering effect. And they also did tau PET imaging in addition to the amyloid PET imaging. However, unfortunately, not every brain area showed convincing dose-dependent tau brain lowering effect. In the medial temporal lobe, there's indeed a dose-dependent, statistically significant, as suggested by these stars, a decrease of tau in the brain. However, in the temporal composite or frontal composite, the results are not statistically significant in the low dose groups. So at this point, you might want to ask, so the clinical efficacy is mixed. It better not have a lot of side effects. However, that is not the case. And here is a table that presents the adverse events that have an incidence of bigger than 10%. And as you can see, the amyloid-related imaging abnormalities, edema, meaning brain edema, as well as microhemorrhage, and superficial siderosis all happen in pretty significant proportion of patients. In the ARIA-E side effect, it actually happens in up to 35% of the patients that are treated with high-dose aducanumab. And the takeaway is from this slide is essentially that there is a significant dose-dependent increase in ARIA-E and as well as ARIA-H events related to aducanumab.
Tell them what siderosis is.
I think it's hemosiderin deposits in the brain.
That's not good.
No.
It's from the hemorrhaging.
Yes. So here we sort of want to take a closer look at the ARIA side effects from aducanumab. And I've sort of marked the box for the ApoE4 carriers. And as you can sort of see, when compared to the non-carriers, they do show a significantly more side effect in both high dose and low dose groups in significant proportion of patients. However, if you shift your attention to this box right here, you can see that around 70 to 80% of the patients are actually asymptomatic, while a significant minority, around 20 to 30%, are indeed symptomatic. And Biogen went on to sort of say that the symptoms that are commonly seen in patients with ARIA are typically signs of increase in intracranial pressure that we typically see, including nausea, vomiting, dizziness, vision change, or headache. They usually resolve within 4 to 6 weeks, however, and the majority of the symptomatic patients can actually continue treatment. So here I sort of show 2 images of the edema as well as the hemorrhage that can happen due to aducanumab. And as you can see, the ARIA-E can happen both in both white and gray matter. And this is on the left side, here is an example of microhemorrhages as indicated by these black dots. And these are some hemosiderins or superficial siderosis in the brain as marked by these sort of thin black lines. So as a result, Biogen sort of required a baseline MRI prior to initiation of aducanumab, as well as prior to 7th or 12th infusions, because I think the risk is highest around the 7th infusion. If severe hemorrhage related to treatment is observed, the patient's treatment should be stopped and they should be followed up clinically, as well as have a follow-up MRI done in 1 month to ensure imaging stability and clinical stability prior to reinitiation of treatment. So sort of the takeaways so far from the trials and Dr. Knobman's paper is that, number 1, aducanumab has showed mixed or questionable results of clinical efficacy, as indicated by this neutral yellow arrow here. Aducanumab is likely effective in reducing beta amyloid pathophysiology in the brain, as indicated by this upwards green arrow. And aducanumab carries significant risk of harm, including brain bleed and brain edema in up to 35% of the high dose treated patients, and as indicated by this red alarming downward arrow. So now I sort of want to switch gears to some of the things I wanted to discuss about this drug. So first, I want to sort of talk about the FDA approval process of aducanumab, and it is named the Accelerated Approval Program. Essentially, the Accelerated Approval Program was typically used in cancer drugs, but it essentially approves a drug based on a surrogate endpoint instead of a clinical efficacy endpoint. So the surrogate endpoint used in aducanumab is the reduction of beta amyloid in the brain using PET amyloid scan. And they did not just say that, they said these studies are known as, these studies need to be sort of confirmed by a phase 3 confirmatory clinical trial. So the takeaway sort of from this slide is that FDA actually did not say aducanumab is proven to be effective. They said, they actually said the efficacy is to be proven in the phase 4 trial. And what they essentially said is that it's likely to reduce biomarkers, but efficacy is to be proven. So the unfortunate thing about the phase 4 clinical trial that is to be carried out by Biogen is that FDA has allowed Biogen until August of 2029 to complete the phase 4 trial. And in an ideal situation, millions of people would have benefited. However, you got to think about the flip side. Money would have been wasted, benefit would not have been achieved, and harm may have been caused. So you naturally ask, why did FDA approve aducanumab then? And FDA actually wrote a letter that sort of addresses this concern by clinicians and scientists. They said more than 6 million Americans are suffering with Alzheimer's disease, and the number is expected to grow. It is the 6th leading cause of death in the United States. They also said Aduhelm, which is the trade name of aducanumab, reduces beta amyloid in the brain, and by reducing the plaque, patients are reasonably likely to benefit because it sort of predicts important benefits to patients. The takeaway from this slide is essentially aducanumab is approved because of overwhelming need from patients and families and reasonable chance of benefit based on what we know about the pathophysiology of Alzheimer's disease. The implications for other drug makers, you may think, is they may actually go ahead and proving meeting of surrogate endpoints like Biogen did, and reasonable benefit and submission of their drugs for accelerated approval. So why not do the same, right? So now I sort of want to switch gears and talk about some of the issues with the label of this drug. And on the left side, I sort of copied, the label of aducanumab. And it says, aducanumab is indicated in patients with MCI or mild dementia stage of Alzheimer's disease. However, what it does not say is the patients need to be confirmed via CSF studies or PET scan of their amyloid pathophysiology. However, if you look at the study design, everybody had confirmed amyloid pathophysiology. So how do we know the MCI or mild dementia is due to Alzheimer's disease without CSF studies or PET amyloid scan? Do we just sort of judge it clinically and prescribe this treatment to everybody meeting the mild dementia or MCI criteria? And now I sort of want to talk about an issue.
We also know that many people without cognitive disturbance have beta amyloid in their brain.
Right, that's right. And now we sort of move on to the cost issues of this drug. And this is something that we sometimes don't think about, but is significant in this case. So Biogen had announced that aducanumab costs about $56,000 annually. However, that is based on an 163-pound adult at 10 mg per kg. The weight matters because this drug is dosed based on weight. The unfortunate reality is that the average American adult age 60 or older is 195 pounds. So the real cost of aducanumab is about $61,000 a year by calculation. There are about 6 million of Americans living with Alzheimer's disease and 2 million meeting the criteria for this drug, namely MCI or mild dementia. If you times $61,000 by $2 million per year, and the cost is, voila, $122 billion per year. if you look at this is a pie chart of the Medicare spending as of 2018. As you can see, the total spending is about $605 billion. So this drug alone actually would account for 1/6 to 1/7 of the total Medicare spending in 2018. And this is not counting 3 MRIs, numerous specialist visits, and 20 infusion center bills. Because remember, you have to go to an infusion center to get this drug. And I've sort of calculated all that out of pocket. It's around 10 to $20 billion for 2 million patients. So the cost of this drug on the healthcare system is definitely very significant. And now I sort of want to talk about the access and equality issues of aducanumab. Here is a CDC graph of the percentage of adults age 65 and above with Alzheimer's disease by race and ethnicity. As you can see, African Americans and Hispanics have are much more likely to have Alzheimer's disease than non-Hispanic whites. But they're also sort of at the bottom of median household income. So the takeaway from this slide is that suppose aducanumab is not 100% covered by Medicare or Medicaid, those most susceptible to Alzheimer's disease will actually be least likely to afford it. So let's propose a scenario. Suppose Medicare Part B covers about 85% about aducanumab. The out-of-pocket cost would be around $12,200 per year. And that is almost 40% of an average Medicare beneficiary's $29,650 per year annual income. Do you think they would be able to afford it? So now we sort of take a closer look at what the benefit means for a patient. Suppose patients do benefit from this drug. So here I have a CDR scoring table, and here I have the post hoc analysis results. Suppose aducanumab does decrease the clinical dementia rating scale by about 0.5 point, as you can see here. We suppose the patient is coming in with mild cognitive impairment of a CDR score of 0.5, and we suppose over the same period, a placebo would decline by 2. So, because that is the closest number to 1.8. So over 78 weeks, aducanumab can theoretically slow the decline from 2.5 to 2 by making a 0.5 point of difference. And if you sort of take a look at this table, suppose a patient has 1 point in memory and 1 point in orientation and 0.5 point in judgment and problem solving. And after taking this, if they were to take this drug, they would not have the judgment problem, but still have the mild memory and orientation problems. Do you think that would translate into actual functional improvements, such as delayed nursing home placements and problem with ADLs? And last but not least, I want to sort of talk about the implications of the approval of this drug for psychiatrists. And so I want to acknowledge that most psychiatrists will actually not be directly prescribing aducanumab in our normal day-to-day practice, as they will likely be prescribed by memory or dementia specialists. However, if patients do come into our office and they're wondering, hey, doc, do you think I may be a candidate for aducanumab? You might want to refer them for neuropsychological testing to determine if they are a candidate for this drug, meaning they have MCI or mild dementia. And you also want to advise patients with moderate to severe dementia that aducanumab has not been studied in their population. And also in a previous slide, we mentioned that amnestic MCI is more associated with AD. So suppose CSF or PET imaging are not done, then for patients who only have impairments in memory and have MCI, they may actually be better candidates for aducanumab.
Dr. Friedland here, the dementia specialist at University of Louisville in neurology, says he's not planning to use it, at least at this time,
Okay.
at all.
Mm.
That could change.
And we then sort of want to discuss aducanumab in a manner that patients and family can understand. And that includes the mixed results of clinical efficacy, the proven effect of biomarker reduction, and the significant risks of harm, including brain bleed and edema. You also sort of want to remind them of the logistics of 20 infusion center trips, as well as the significant cost of this drug. For patients on this medication coming in for a visit, you want to ask them about the side effects, the signs that they may have developed edema or hemorrhage, including nausea, vomiting, dizziness, vision change, and headache. If answers are concerning, order a brain MRI, advise them to stop the next treatment, and refer them to see the prescribing dementia specialist immediately. And also, last but not least, you want to sort of report serious adverse events to the FDA on their MedWatch website so that they can monitor this drug and just sort of gather data for the public. And here are the references. That is it for my presentation.
Well, one of my first comments is we don't even know if the beta amyloid is a cause of dementia, or if it's a result of dementia, or if it's even, how closely is it related? And it also depends on whether you have a genetic form of Alzheimer's or a non-familial form. And those are at variance. One thing that you said about the cost caught my eye a little bit, and I agree with everything you said. It's astronomical in the cost, but that didn't even include taking care of the people, 1/3 of the people that got edema, hemorrhage, or siderosis.
Right.
So all those people would have been obligatory extra cost.
Right.
So they're saying right away, you go ahead and do a new CAT scan, a new MRI, and so forth, repeated, and then I don't think very many people with edema or bleed would want to continue the study.
Right.
Anyway, so then you're having to follow people with additional tests and clinical visits that aren't even getting the drug anymore. And they may get it again, they may not. But then if they do, well, then it'd be an additional cost.
Right.
So that makes it very questionable to me. And it seems sad that why they didn't just say, let's study this drug a little more.
Right.
And actually, the other interesting thing was that 10-4 vote against approval by the advisory committee of the FDA. Subsequent to the approval, 3 of the 10 people quit over that decision.
Yeah.
Quit the FDA and said, well, if you're going to vote yes, even when the vast majority of us are saying no, then we don't even want to be a part of the committee anymore, I suppose. I don't know what will happen in the long run, but I think that tells us a lot about the confidence of those people who know more about it than anybody else listening to this discussion.
That's right. That's right. Yeah, I did read about that. And yeah, that is alarming for sure.
It is very alarming. It seems to me that a lot of the pressure for this maybe is Biogen wanting to make money. That's, of course, in the issue. It's kind of like the Pfizer people saying, why don't you get a booster before FDA said get a booster?
Right.
It's that same deal, that the money. The other thing is, well, just that's maybe the main point, that and that's about it.
Right. Right. Well, thank you for your comment.
I guess I would say one thing: if they offered the indications for end of life or very severe Alzheimer, and you said, okay, it's really expensive and it's really dangerous, but okay, if you're near the end of life, it might be worth it. But imagine, just put yourself in that shoes. If you said, well, this drug might only marginally help you and has a 30% risk of causing a serious brain disease. It's not just a rash on your skin. A brain disease is 30% of the chance if you get this drug. well, do you want it? I don't think many people would say, I have a mild impairment, but I want to take a chance on 1/3 doing something really bad to my brain.
Right.
And siderosis, I mean, and bleed. I mean, if you have a bleed, you're going to have gliosis, demyelinization, neuronal loss. That's really bad. We know that. And then the other thing, the other fly in the ointment is, does reducing beta amyloid make you do better clinically? And we don't know that.
Right. We don't.
Hey, Will, there's a question on the chat from Nick. Can you see that, or do you want me to read
Yeah,
that?
I can see that. Thank you. So Nick Alexander is asking, in the cognition scale comparison slide, it is only the high dose of the engaged intention to treat and post hoc that are statistically significant. Right, due to confidence interval of the other analysis. Also, was there a treatment arm that included a comparison between participants with cholinesterase administration? That's regarding the second question. I do not think so, and I don't know if Dr. Lippman, you have any more knowledge of whether drug companies typically do those. They probably wouldn't do it in their original phase 3 trial. Yeah, but down the road, the thing is, these medications are so different. One is an oral medicine and the other is an infusion. They're just vastly different, and
in cost as well.
in cost as well. Yeah. Yeah.
And
So
side effects.
right. So I think somebody may sort of study it, but really for a patient and family who's so desperate, they may just try everything and see whether they attack different mechanisms. And regarding the first question, I'm not sure I'm completely understanding it. I don't know if Dr. Lippman, you're able to see that. Let me just flip to the slide. I don't know if Nick is still here.
I'll tell you one thing that I used to notice in my own practice, and just from anecdotal, this is anecdotal only, sometimes on these other drugs, including way back before donepezil came out, the previous drugs, people would say, no, it didn't help until after you quit it. And then they said, oh, in retrospect, maybe it did. But then you're getting so much subjectivity. You're talking about a year later. Are they better a year from now than they were a year ago? That's a pretty fine description. And subject to how their mood is and other things that in their life and so forth. It makes it very subjective.
Right, absolutely. Oh, so Nick says is actually the emerge ITT and post-hoc are statistically significant. Let me see whether I can look at the slide and see what you're talking about. Okay. Yes. Yeah, you can sort of see that both the intention to treat and post-hoc analysis for emerge are indeed statistically significant. They lie below 0. And yeah, are you able to see Nick's question, Dr. Lippman?
I don't see any question.
If you click Q&A.
Oh.
Looks like
it doesn't matter. Just go ahead.
Okay, looks like CL are inclusive of one other than the emerge. Yes, that is correct. The thing about these pairs of studies is that even in the post-hoc analysis, the CL does include 0. And I think they were mostly trying to see a positive results, meaning a decrease in the clinical dementia rating, rather than pursuing a solidly statistically significant result, because the sort of situation they were in before the post-hoc analysis was so bad that it was showing a harm of the drug. So they were like, hey, although this is not statistically significant, it has a high chance of being significant and is showing a benefit now. So they were like, oh, this is good enough. All right. Anybody else have any questions?
Will, this is
We're all convinced that it might shrink beta amyloid.
Yes. Yes, we are. All right.
Well, this is more of a comment than a question, but excellent presentation. I actually thought it was interesting that there were the package insert for the medication does not include any contraindications, which is kind of surprising because, microhemorrhages exist in a lot of different conditions, including traumatic brain injury. You can see that on the GREs imaging on the MRI. So, I was kind of confused by that they did not include either a hemorrhagic stroke or aneurysmal complications or TBI as contraindications for the medicine.
Nor did they say that you had to prove you had amyloid in your brain at all. So you're going to theoretically be giving this to somebody with vascular dementia just because you don't know any better, or that has hypothyroidism or who knows what, and you'll try to see if it made them better because of shrinking their beta amyloid, which may be not even present. Because you're leaving it up to the individual doc. So somebody can say, I got a rich patient here that wants the drug, let's give it. I'll put him in my infusion center every once a month. That's money, the cash register's ringing positive every month.
And my personal experience, I was in the geriatrics clinic the day that this was approved, literally the day that it was approved. And I had a couple of patients actually ask me about it that day. So, it's people are desperate, I think, and so they're desperate people do desperate things to help themselves. And, I think this is a product of that. But at the same time, I think it's our job to show them what is real and what's not. But we'll see how it goes.
Of course, that means the FDA is also desperate. They want to prove that they're good guys. They're helping lots of folks. And there's a huge Alzheimer Association push for getting this drug. So there's a political, social, and economic influence. And to me, the other bad thing is that this comes out right when we're trying to say, let's trust the FDA for vaccines. And if they had deferred and said, let's wait a few more months or a year and do another study and then see, everybody would have said, boy, those guys at the FDA are really trustworthy. Here we're saying, oh, do this. Oh, no, well, maybe not. It might kill you, but do it anyway.
Yeah. I think Dr. Oliva has a comment. He says, another reason the medication was approved was because of the disease advocates. I was listening to NPR and Alzheimer's disease advocates were really happy this medication was approved. Yeah. And I've heard that too. Yeah. Yeah. They were very vocal apparently about this medication. And, there's 6 million Americans suffering from it. So patients' families, patients. So thank you for your comment. Yep.
And in the meantime, now with the accelerated approval, that means a couple of things. You got to wait 10 more years essentially before you find out the results. So we're going to be spending, what is it, $61,000 a year per patient on a drug that we were not going to find out until 10 years from now. And sometimes these accelerated approvals take longer than the prescribed period because, I don't know, there's an epidemic or some other problem that comes up, or the data gets lost, or something happens to the country or the protocol to delay it. The other thing is it might discourage further research. It has, in addition, it has put the accelerated approval process under greater scrutiny, this drug under greater scrutiny as well. So the next time the FDA comes out with an accelerated approval process, immediately they're going to be people saying, wait a minute, the last time they did it was somewhat questionable. Is this one questionable? Even when it wouldn't have otherwise occurred. So there's a big danger in doing these accelerated approvals unless it's very well documented as the reason.
Yeah, I agree with that 100%. I think Megan Pennell has a question. I'm curious about your opinion. Do you think any families will go for this if their loved one only has mild impairment? I think Dr. Lemon, that's a good point, because if you know the side effects of brain edema and brain bleeding, and your family only has mild impairment, why would you go for it? But at the same time, this drug is indicated for mild patients. So I wonder whether, the labeling being indication for mild patients is sort of, it will sort of hurt their sales of this medication to patients and families.
If the doctors tell them the truth about the side effects.
I think Saba asked a pretty interesting question here, is that, is the price creating a bias in us as well, right? So what do you think about that?
Yeah, absolutely. I think just the fact that it's so expensive is sort of, suppose this drug was sort of like, it costs minimally like $5 per year or $5 per month, then we probably will be more, I would probably a little more, I guess, leaning towards prescribing it when it's $61,000 to either the patient or the country. Then I would think really, really carefully and select my patients really, really carefully.
So that kind of brings up.
So far, insurance and Medicaid have not said they'll cover it. Where are most of the people with Alzheimer's? Medicaid patients. So that means so far, most people are not going to have it covered.
But that kind of brings up, Will, what you said, that kind of brings up an interesting ethical question, right? Like, do you do what's best for the patient, or do you do what's best for like society in general? Because if you think that it's best for your patient to get this drug, then it shouldn't really matter what the cost is. If you think that there's going to be, that it actually would work for them and improve their outcomes. If you don't think that it will work for them and improve their outcomes, then you should not prescribe this, no matter what the cost of it is. So that's a very good question. Yeah. Saba.
But you got to balance that against 1/3 of them are going to have a fairly significant side effect.
Yeah, absolutely.
I mean, like when you give donepezil, you're not thinking really much at all about side effects. You said, okay, it costs a couple of $100, maybe here and there, but okay, but it's not going to hurt you.
Yep.
And that's right. A big deal difference.
Right. The fact that it doesn't hurt.
30%. And especially when you're talking about your brain, you're not talking about maybe a cardiac block that goes away the next day when you stop the drug, but swelling in your brain or hemorrhage. You get hemorrhage in your brain, that's going to be there for the rest of your life. I mean, it may heal, but you're going to have gliosis, demyelinization, and loss of neurons, right? Automatically, by definition. And maybe siderosis.
Absolutely. I think Arthur Oliva said the FDA, like any organization, is fallible to external pressure, like the disease advocates, and disease advocates may not have the best scientific experience. An anonymous attendee said post hoc statistical significance is not to be trusted. Cherry-pick data that supports the idea with inadequate power and should not supplant prospective data. What's your take on that, Dr. Lippman?
I didn't really catch what you were saying.
They essentially said post hoc statistical and significance is not to be trusted because they cherry-pick the data that supports the idea.
Well, that just makes it all the more controversial and a bigger conundrum to think about. It's just, right. It just gets, to me, it just looks not advisable. Right. Now, it is true that during an accelerated trial, they could be 1 month into the trial and say, no, let's take this drug off the market. Or they could say, oh, no, it was so good, we'll go ahead and give it full approval. So you don't know. It's not that we have to wait the full 2029 or something. It's not necessarily that. It's you have until this period to do it. So theoretically, a month later, they could say, good gracious, this is dangerous. We have 80% failure.
That's right.
We don't know.
Yep, we don't.
It seemed to me it's still better to have not done the accelerated, say, let's do one more study and look at it again next year.
Right, that's right. But now we have to wait until 2029, and
Maybe not. They might just,
maybe they will terminate it early or something.
or they may figure it's not worth it.
Right,
The
right.
company might say, let's just throw it away. Because maybe somebody else is doing one of those other MAB drugs and says theirs didn't work either. And they say, well, then maybe it's just not worth it.
Right. That makes sense.
It's hard to predict the future. You can't predict the future, let me tell you that.
All righty. I don't think we have any other questions.
Any more comments or questions? Well, Will, I think you did an outstanding job. It's amazing stuff. It's just totally amazing stuff.
It is. So thank you, Dr. Lippman, and thank you everyone for showing up to the talk today.
Thank you.
Yeah.
And Rob, thank you for sponsoring this event. Wherever you are, if you're still
Happy to do it. Happy to do it.
All right, let's roll it. Thank you everybody for coming and good luck to you. Have a nice rest of the day. Bye-bye.